at my slides, you know that my farm animals at home help teach some of these concepts. That's how they earn their keep at home. So here they are presenting to us talking about ethics. So the field of ethics involves developing, defending, and then recommending concepts of quote unquote right and wrong behavior. And so ethics looks at the nature of our own individual good and then the nature of social good and how those two relate to one another. And then in modern ethics, it's about recognizing what our duty and moral obligation is. Thankfully, the ethical codes do change over time. They change in response to how our society changes, which then affects how our laws change, how our training changes, and how we change. Each of us, I love this ECHO group for a number of different reasons. One, I love how just all the different disciplinary avenues that are represented here. So we've got physicians, and we've got nurse practitioners, and we've got social workers and counselors and case managers and so many other folks here. And so each of us in here have our own professional ethics codes that we're required to follow. And so it's on us to understand the principles of those codes. We got to know the codes to begin with. We also have to understand how our own personal values fall in line with those codes that you're assigned to, or sometimes they don't fall in line. So, when your personal values don't align with your professional's ethics, then what do you do? Who do you lean on when you need help making an ethical decision? And then an additional tricky area is when your values may not align with the values of your fellow treatment team members. So then how do you all collectively come to a decision about what's kind of the best decision to make here? May not always be the right decision, but the best fit decision. We need a foundation to our healthy ethical practice, and we obtain that by honoring these 4 keys. So first is recognizing your strengths and limitations. Includes our scope of practice. All of us in here have a different scope of practice. Key 2 is respecting the tiers of ethics. So in a minute, I'm going to talk about the 5 tiers of ethics and how we figure out how to make our decision based on what's number 1 and what's number 5. Key 3 is seeking continuous learning. It's exactly what we're all doing this afternoon. We want to give ourselves the opportunity to expand our knowledge base on all aspects of being a healthy, helpful professional. And then key 4 is making that rule. So this is about establishing that norm of behavior against maybe which exceptions could occur. So those are the keys. Let's talk about those 5 tiers. So when we're in the process of making an ethical decision, we get guidance from each of these tiers. Tier 1 is the federal level. It's the highest tier. It includes federal statutes that have to be carried out by all states. Next down is the state level. The state tier is informed by federal requirements, but may often include directives on how to carry out federal laws within their state. Tier 3 is our licensing or credential level. So we all have mandates, or some of us have mandates from our credentialing boards that we have to abide by. Tier 4 is our agency level. So there may be rules or standards in your agency's policy and procedure manual. And then tier 5 is that personal level. So each of us in here have our own internal ethical code and morals. And these are created by our personality, our observations, our experiences, and what our goal is in that given moment. And so what happens when these tiers conflict? So let's say your agency has a particular policy, but that policy goes against your licensure ethical code. What do? In this case, you follow the more stringent code, which is generally the tier above you, but not necessarily always. Oh, I always mean to pull these up at the same time. Okay, so what is an ethical dilemma? It is a challenging situation in which it is difficult to decide on what's the most appropriate or the most ethical course of action. And so often in these decisions, what will happen is you'll have multiple ethical principles at odds with each other. And so to meet the needs of one, you will have to compromise the needs of the other one, which if we've got any black or white thinkers in here like I am, boy, that's really difficult. It's often impossible to make the absolute right decision or the correct decision in that situation. It's really about making the best decision that you can given the circumstances. So again, reaching out to colleagues for suggestions on recent dilemmas. Here's the dilemmas that were shared with me and or requested to discuss for future guidance. So we'll review each one of these, and then along with that, there will be a couple of case examples. So the topic of dual relationships was presented by me, and Dr. Miller did a wonderful job of presenting that case earlier. So what happens when a treatment team member's family is in your MAT program? The second issue that came up was advocacy. What happens, was the specific case example, and then again, we'll talk about it more broadly. What happens when a patient or patient's family member asks you about your political views? And then the last one is patient death. What can we report? When can we report? And that one is almost an even clearer kind of black and white example of two ethical dilemmas really at odds with each other. So first, we'll talk about dual relationships. So, and I'm going to be specifically talking about therapy, and some of that extends to the other therapeutic relationships that take place in an MAT agency. So in therapy, dual relationships occur when a therapist has a second relationship with a client beyond the professional therapeutic relationship. And now that term relationship is pretty broad. And so here's some examples. So it could be that there's a social dual relationship. Maybe the client and therapist, they have other social interactions outside of their individual or group therapy session, and they become quote unquote friendly. An example of professional dual relationships would be maybe the therapist and client are colleagues, such in academia or a shared workplace. We'll talk about where that happens if you are working alongside peer recovery support specialists that may also receive services with you. There's business dual relationships. So the therapist and client become business partners or have an employer-employee relationship. There's communal. So this happens a lot in our smaller rural communities in West Virginia. The therapist and client share a community. They, for example, living in the same small town or belonging to the same religious organization or potentially going to the same peer recovery meetings. There's institutional, which would be, when dual relationships take place, they're sort of inherent in certain environments like the military, like hospital systems, like the prison system. And then there's also digital online. This is when the therapist and client connect on social media platforms or have other online interactions. Some research sites will talk about there being a sexual romantic relationship as a dual relationship. However, that's not a dual relationship. That is just straight up sexual misconduct. So there's no dilemma about that. That is black and white. It should just absolutely, positively never, ever happen. That's my one soapbox for the day. So aspects to consider with dual relationships are, they really are harder to avoid in small towns. So we can give some, oh, well, this is just what you have to do, and this is the hard and fast way you have to handle it. But that's easier said than done when you were potentially the only therapist in your small town area or the only peer recovery coach in your small town area. So not only are they harder to avoid in small towns, they're harder to avoid in the recovery community. We just gave an example of that, of what happens when you have peer recovery support specialists working at your agency where they also receive services. The potential for exploitation and harm to the client does make it crucial for therapists to be aware of and avoid dual relationships if possible, especially those that could impair their judgment or compromise the therapeutic process. So when possible, we want to avoid them. I would say today, given the availability of therapy with teleservices, I think now more than ever, it's been a little bit easier for therapists to avoid dual relationships because now we just have a bigger group to be able to refer patients to for therapy if we're realizing we can't remain in that therapeutic relationship. We try as best as we can. This is a little bit closer to a black and white rule of it's really best practice to not begin therapeutic relationships with people that you already know. And in the beginning of your therapeutic work with somebody to discuss dual relationship boundaries ahead of time. And so what that means is review what a dual relationship means with patients. They likely may not know what that means. Review the dynamics of your working relationships and what your limits are with things like confidentiality, with things like communication, and with things like socialization. So dual relationship case examples. Again, Dr. Miller gave a fantastic job earlier of examples. So example one of your treatment team members, family member, one of your treatment team members, family members enrolls in your MAT program, which is the only program of its kind within 50 miles. So what would you all do? And this is an opportunity to give Dr. Miller feedback on how do you feel like they handled the situation? What would you have done the same? What would you have done different? And please feel free to, I'm going to open my chat window, which I'm not always great at doing. So feel free to enter in the chat or to just unmute yourself and give some feedback. I'm going to move this over here.
I know we have a larger group up here, so we have that kind of going for us. But usually, because I'm from Preston County, which is far from Morgantown, it's happened to me many times here. But usually, I try to defer to like another case manager, another therapy group. That way, I'm not involved in their care whatsoever. Obviously, if you're a smaller
Yes.
clinic, that's not really a good solution. But that's kind of what I've done in the past, at least.
Yeah. Jordan, I think that's the best first step to talk about it. If possible, let's refer to another team. Can we avoid it completely? Again, some of our locations, that's not an opportunity, but for a place like us in Morgantown, that would be our first step and almost a rule is just let's have them see another provider or another team. So great suggestion. To me, the second step down from that would be exactly what you did, Dr. Miller. Is it sounds like you sat down with the patient and the family member ahead of time and said, here's how it's going to go. And you made those boundaries really clear. We're not responsible for people not following those boundaries down the road. You're responsible for your side of the street, which you did, which was made it very clear ahead of time. This is how we'll handle that.
So one thing I implemented after this, and it was because, like I said, he was I think he was our second or third patient that we ever did an intake on. I made it not a policy rule, like it's not written anywhere, but we do not have family members accompany unless they are special needs. Like, so
Yeah,
I just didn't think to say you're not to be in the room with your brother. And
sure.
so when they reported back to me, because I did not do that, I was not there for the intake, I said, oh, we need that. Let's
Yep.
nix that. I get that she clocked out and made a big deal that she was, but I said, so that
Yeah,
was my first red flag. If that tells you that I was
sure.
already starting to get worried, was that you weren't supposed to be a part of the care. And then we clocked out and
Yep.
was there in the most intimate, right? At the intakes where you get all the details. So
Yeah,
that was one very early on. So now intakes are done by themselves unless you're special need and you need assistance for any reason.
sure. Listen, show of hands in here, and you can raise your hand or put your Zoom yellow hand up. How many of you now have a policy or a rule because you didn't do it a certain way one way and it sort of went haywire? I can definitely raise my hand on that. For example, once upon a time, we used to have couples in the same therapy group. Now, just imagine how poorly that went sometimes for us to go, oh, we should in fact never allow this to happen.
Hey, Lauren, just kind of a thought I had. Did you talk to the brother at all about not having the sister involved? 'Cause I ran the case before where one person, like significant other, wanted to be involved, and that person actually didn't want to have her involved. If that makes sense. I don't know if that was kind of something you
So
crossed on.
I will say this. He was a guy of very few words. His sister, I think, has been raising him since a child. So anything sister says, he adamantly agrees to. And so one of the reasons we were trying to get him on these just check-in appointments where sister wouldn't sort of see him in the light of like a med group day was to try to get him to talk to us outside of sister even knowing, and just he anything she said, they had their stories kind of together, and he is very codependent on her, including income wise. He lives with her parents still. He is not intellectually delayed, but he still lives at the house. She comes by 5 days a week, helps make dinner. He doesn't always have transportation. She provides it. So they're actually also sort of a great case in enablement as well,
Mhm.
because when he needed someone to probably say, hey, what's going on here, she did the opposite and advocated that we all were liars.
Yeah, yeah.
Yeah.
Yeah, so to recap those steps, one is, can you be removed from that family member's treatment team? Can you have them off to the side? If you can't, can you set perimeters from there? Can you and that family member meet with the treatment team ahead of time and lay out rules for confidentiality and involvement and not speaking out on behalf of the patient? And then as we're thinking about this case, for all of you to think about, does it change your answer? So this reads, you have the only MAT program in the area within 50 miles. Let's say there's 2 or 3 other MAT agencies in your town. Would that change your answer? Would you take on that patient or not enroll them?
And so there are 2 providers. So one's a very large provider that this patient had a bad experience with. So that was, and then the other one is a provider who I'm trying to be as polite as possible. She does
Sure.
marijuana cards while also doing like it's
Gotcha.
whatever
Yep.
it's all her spectrum of care is quite robust. And
Yeah.
so that was the reasoning that they gave that they did not want to use that program. He has since moved to that program. And she used I'm not quite sure how that rolls, but apparently she used his days of sobriety based on what he said. And so he's only having to do urine drug screens per sister who told everyone how wonderful she is like once a month.
Yeah.
So
yeah.
And I think they're only point of cares and they're not getting, so who knows how reliable they are, but
Gotcha.
yes, but I when she announced he was doing wonderful, I said, I'm so happy he found his fit. And
Sure.
yeah.
Well, I'm not hearing from the chat, or I'm sorry, I'm not seeing in the chat or hearing from anybody that folks would have done anything differently there. So Dr. Miller, I think you all took the great steps. It's not always that, because we're not responsible for the outcome, it's not always the outcome that we wanted, but it's a reminder that we did our part.
Thank you.
Yeah. Second case on here. So you and your spouse join your best friend at dinner to meet the new person she's dating, and her date is a patient in your therapy group. What would y'all do? Again, feel free to unmute yourself or add thoughts to the chat. So steps to consider here. What are your ethical codes that you have to abide by here? Let me go with that.
I've actually had this situation happen. So I'm a pretty awkward person in general, for you guys don't know me. So
no, you are not, Jordan.
But I try to, in all seriousness, try to make it like I don't know the person, if that makes sense. So trying to kind of protect that boundary. But I think my wife at the moment kind of knew I was being awkward, so she kind of caught on. But that's kind of how I played it. I actually didn't really know them. That they kind of played into that too, because I don't want to make them feel awkward. But that's kind of how I did it, anyways.
Yeah. So Jordan, first of all, Jordan, you were not awkward at all. You were awesome. And also, that's absolutely the right ethical code here is confidentiality, is that we cannot break that confidentiality code first. So that would be my recommendation, is to not break that confidentiality code in the meeting. In the dinner. We can't control how other people are going to decipher our behaviors. Generally, what I would do is talk with the patient next time, maybe before the next therapy group, kind of reach out to them a couple days later when I'm in the office and say, hey, I just want to talk with you about the social interaction that we had last week. There's a potential chance that's going to happen again since we have the same person. Let's talk about, parameters and boundaries here. And that could be where you set, boundaries of, listen, if there's going to be another gathering, what I'm going to ask is that if a gathering's ever happening at my house and your girlfriend invites you over there, I'm going to ask that you not come, just because that's a part of my therapist, boundary code. Again, you get to determine those. Questions to ask yourself: should you move the patient to another therapy group if that's possible, or should you remove yourself from the therapy group if possible? What would you consider when making that decision to do that or not do that?
So I'll say, so family medicine is my background. I've been doing that since I graduated residency in 2012. And so things like this happen all the time with my patients, all the time. And I'm especially now that I'm in Lewisburg, which is a much smaller town, and all of the school uses our little clinic, so this is run by their colleagues. And so oftentimes if I think it's someone who I think we could be connected in some ways, I'll often say when I'm establishing their care, I will never acknowledge this relationship. Um, and so that's one, and then they can choose. And so I'll say, if you choose, I will never be upset by it. But
Yes.
I want you to know that if someone asks or if we're talking, I will act like I have no clue. But I'd say that because I've had patients that felt like they were slighted before, like
Sure, they got offended.
yes, because I was acting like I was ignoring them.
Yep.
And so then I started in general, when I take on new patients, say, hey, if I'm at Walmart and we run into each other, I will not say hi to you. But if you say hi to me, I promise you I will wave back. And so that comes at, especially here when I worked in a city that was about the size of Huntington, West Virginia. It did not happen the way it happens here. But when I first moved here, I offended someone really fast at a grocery store by
Yeah.
doing my usual. And so now I just sort of say, if you wave to me, I'll be so excited to say hello. But I will never make that contact because this is your space when you're grocery shopping versus
Yeah.
out here.
Yeah.
So
Oh, well
that's
said, Dr.
one.
Miller.
Yeah.
Yeah, great idea of sort of setting that up ahead of time, explaining to patients ahead of time what will happen if those situations occur. So it's not just sort of out of nowhere if and when it does.
Yeah. And
And
again, that came from a negative event when a
yep.
patient told me I really hurt their feelings because I
Okay.
didn't say hello to them.
Yep.
So
Yep. That's my favorite way of learning lessons. Anybody else do anything differently there? Yeah, for me, I'm going to judge that comment, have that conversation with the patient afterwards, sort of talk about it, see how it goes. I'm going to get supervision consultation from my supervisor to decide, do I think it's best for them to move out of my therapy group? What's their current relationships in that group with? Do they have established strong therapeutic dynamics from the other patients to where it would feel unfair to move them into a different group? Or maybe they're new in there and haven't established those relationships, so it's good timing to move them to a different group. Do I work with enough staff to potentially move myself out of that group or not? Would be things I'd want to consider. And then for your own personal ethical values, I'd want you to think about how would the situation changed if you knew that patient had recently returned to active IV fentanyl use? What that sort of bring up for you, knowing that your best friend is in a relationship with that person? What also, if you know the patient was recently diagnosed with HIV, how does that trigger any personal values? And would you be able to still maintain, your licensing and state and federal ethical codes there? So just some things to think about. I'm seeing what time it is. Okay, next slide. We're going to talk about advocacy. What is political and what is a part of our ethics? So I don't know about you all, but I really feel like the current political climate has been coming up in my individual and group therapy sessions a lot recently. And I'm regularly having to check in with myself on what is and isn't ethical for me to say. I really want to shout out Sarah Leifheit on the call here. She runs a monthly consultation group for us therapists here. It's called Social Impacts of Treatment. And it gives us the space to talk through how to handle and address everything that's going on. So, kudos to her for recognizing that this is the time that we really need to be able to hold that space for each other to figure this out because it's messy. So it's been a way, for me, it's been a way to kind of help figure out what is political, what's a part of our personal values, and what is required of our licensing ethics. And so I'll talk specifically to our counselors and social workers on here. So we either follow the ACA or the Nassau Code of Ethics. So advocacy is included in the ACA Code of Ethics. It's a little bit broader. So the ACA code reads, when appropriate, counselors advocate at individual, group, institutional, and societal levels to address potential barriers and obstacles that inhibit access and/or growth and development of clients. It's long-winded. I do believe the Social Work Code of Ethics far excels in this area, as they have an entire set, that's one tiny code. It's code A.7.A. Social work has an entire section. It's called ethical responsibilities to the broader society. And included in that section are a couple of different subsections about social welfare, about public participation, and then social and political action. So it is included in their licensing code of ethics. Social workers should promote social, economic, political, and cultural values in institutions that are compatible with the realization of social justice. Social workers should facilitate informed participation by the public in shaping social policies and institutions. And social workers should promote conditions that encourage respect for cultural and social diversity within the United States and globally. Social workers should promote policies and practices that demonstrate respect for differences. Now, if you notice, the counselors was a little broad. It said, well, when it's appropriate. But social workers was a little bit more direct. It was like, no, guys, this is a part of your code of ethics. Any of the social workers on here or counselors, feel free to disagree with